Greetings and welcome back. My name is Lois Wessel. I'm with the School of Nursing in the Department of Family Medicine, and I'm delighted to introduce three fellows for our second panel here. Woo! I will introduce the three panelists first, and then we will hear from each of them. So our first panelist is Amara Salim. She is the Maeve McKean Fellow, and this fellowship is through the Global Health Institute, and it's in memory of Maeve McKean in her dedication to public service. It honors Maeve's legal and public health career and her devotion to serving others, and it supports research focused on public health and human rights. The next research project comes to us from Kayla Wantumi, a 2025 Laidlaw Fellow. The Laidlaw Scholars Program supports 6-week research projects during the summer and allows participants to develop their leadership skills and research experiences. Our final panelist this morning is Alea Hicks, who was a summer research fellow with the Center for Research and Fellowship. So let's welcome Amara for our first presentation.
Hi everyone, thank you so much for being here. My name is Amara Salim and I am the Maeve McKean Global Health Fellow for this year. My project is titled Barriers and Facilitators to Management of Gestational Diabetes Mellitus Among Low-Income Women in Karachi, Pakistan. So before I get into what exactly that means and break down that really long title, I wanted to talk a bit about what this project means to me. So the Maeve McKean Global Health Fellowship is a fellowship that honors Dr. Maeve McKean, who spent most of her life and career working at the intersection of global health and social justice, and I'm so honored that I was able to continue on in her legacy by pursuing a project at that intersection as well. The reason I chose this topic and chose to go to Pakistan for this research is because I am half Pakistani and half Indian, and it was really important for me to incorporate my own cultural heritage into this project. And also diabetes is a part of my own personal experience with many of my family members who also have been diagnosed with diabetes, so that's another reason I chose diabetes as a focus for this project. On the left is a picture of me and some of my family in Pakistan, and I wanted to feature them because they were a big part of the reason I chose to go to Pakistan for this project. And lastly, but not least, this project is important to me because I really wanted to be able to work with and spotlight underrepresented populations in research. So a lot of the women with which I worked were considered low income in Karachi and also from marginalized ethnic groups. And so for me, this was really an important opportunity to use my privilege and this stage to spotlight their experiences and their narratives. So what exactly is GDM, or gestational diabetes, and why is it important, and why is this project important? So gestational diabetes mellitus, or I'll refer to it as GDM from here on out, is diabetes that occurs at the onset of pregnancy and usually subsides at the end of pregnancy if it's managed well. GDM can be managed through a combination of diet and exercise, but it can also be managed with medication and insulin. If it's not managed well, GDM does have implications for the health of the mother and the baby. So mothers with uncontrolled GDM can potentially have a higher likelihood of developing type 2 diabetes post-pregnancy, and there are implications at birth and complications that can occur at birth for babies born to mothers with uncontrolled GDM. Why is GDM specifically important in the Pakistani context? So South Asia and Southeast Asia have a particularly high incidence of GDM, and the clinic at which I worked had a very high incidence of GDM at 21.8% when compared to the global average incidence of GDM at 14%. Another reason GDM and studying GDM in a qualitative manner was important here is because there's generally a lack of literature on prenatal care, experiences with diabetes, and gestational diabetes in Pakistani populations. So this research really seeks to bridge that gap. And then finally, like I mentioned, this research is important because it seeks to amplify women's experiences and kind of spotlight their narratives as well. So what exactly were my research questions? What was I looking at and asking about? My main research question was looking at the structural factors that influence an individual's ability to manage care for GDM. I was also subsequently interested in how people assess constraints and/or support in pursuit of their access to care for GDM. And then finally, I was interested in what competing narratives about responsibility could tell me about challenges to access care. So before I break down what exactly I found within these questions, I wanted to talk about the existing literature and how my research looks to kind of bridge the three buckets of existing literature. The first bucket of existing literature that I've been looking at is literature on experiences with diabetes in South Asia. Another bucket of existing literature that I've looked at is literature on experiences with prenatal care in Pakistan and also in India. And then finally, I've looked at literature on more theoretical questions of diabetes, clusters of disease, and mental health across the world. And so my research seeks to bridge each of these kind of buckets of research to, again, fill a gap in the research. So a bit about what I actually did in Pakistan. Like I mentioned, this is a qualitative research study. So I worked at Indus Hospital and Health Network, which is a nonprofit hospital located in Karachi, but it operates throughout the country of Pakistan. And it provides services completely free of cost to all of its patients. And for that reason, 95% of the patients that go to Indus Hospital are considered low income in Karachi. So what I did was I worked at their gestational diabetes clinic, which operated from 8 to 11 a.m., 6 days a week. I would sit in the corner of the clinic and conduct field observations. And then I also conducted 28 formal semi-structured interviews with patients and 3 formal provider interviews. And then now I'm currently in the data analysis stage of looking at my interviews and my field observations. A bit about the actual context and people that I worked with, because this is really important to me and also drives a lot of the meaning behind the work that I did. So I really wanted to make an effort to understand the context of Karachi, the city I was in. I spent a lot of time going to local sites and touring. This is a picture of me in a jewelry and fabric market. It was also really important to me to develop relationships with my hosts. So the middle picture there is a picture of me with some of the resident physicians there who facilitated my work, and then also some of the nurses at the gestational diabetes clinic. And then lastly, another thing that was really important to me was developing this project and working on this project while incorporating local Pakistani perspectives. So my research partner is actually a medical student who is learning at Aga Khan University in Karachi, Pakistan. Her name is Shafan, and we are continuing to work on this project together. So that's me and her in the last slide there at the hospital. A bit about the hospital itself. So I know I mentioned that Indus Hospital is a nonprofit hospital. I was working specifically in that small room pictured on the far left, which is the gestational diabetes clinic. It was open every morning. They had visits from 8 to 10 a.m. and then a GDM class from 10 to 11 a.m. So I observed all of that every day for about a month. The clinic and the hospital that I was in is located in the Koranki district of Pakistan, which is a densely populated district, primarily consisting of low to middle income residences, and it's also a highly industrialized and manufacturing area. And then of course this is all taking place in Karachi, Pakistan, which is a coastal city in the south of Pakistan, and it's the most densely populated city in Pakistan with a population of 20 million, although some of the locals estimated the population at about 30 million. So getting down to my actual research, what did my participants teach me about living with gestational diabetes? Like I mentioned, one of my biggest questions with this research was understanding the structural factors and institutional factors that contribute to an individual's ability to manage their disease. So some of the structural factors here included cultural norms, socioeconomic status, family support, the healthcare system, and also government support. So each of these kind of structural factors impacted whether an individual was able to manage their diabetes, and I've pulled 2 quotes to show this. The first quote is when an individual told me that it's hard for her to manage her diabetes because she's joint family or she lives in a multi-generational household. She said she has to make food separately for herself because her family eats different food. So here we can see how family support can be a structural factor, and in this case, it presents a barrier to disease management. Another individual told me that buying test strips for glucose was difficult because of how expensive they are. And so in this example, we can also see how socioeconomic status and cost barriers can be an issue in terms of managing gestational diabetes. Here I wanted to highlight the distinction between management of GDM and access to care for GDM. So I divided management of GDM into 3 buckets. The physical aspects, so like walking, eating right, checking your glucose, those are really the physical parts of managing this condition. Mental aspects are learning about the disease itself, remembering everything that you have to do to manage the disease, and then of course social, so understanding how so accessing care and accessing healthcare resources and family resources to manage your condition. So this quote at the bottom, I think, shows the distinction between managing and accessing care. A participant told me that her family helps her manage her gestational diabetes. She said, "My husband is very nice. They take care of everything. He tells me to walk. Since outside it's really dirty in the street all the time, I can't go out, and the house is really small, so I can't walk here." So here in this quote, we see the distinction between managing versus accessing care. In this situation, this individual is trying to manage her care physically by exercising, by walking. But there are 2 things that are either presenting a barrier or a facilitator to her being able to walk. The facilitator is her family support, and the barrier here is her external environment. She doesn't have access to a safe environment to walk and exercise and move her body. And lastly, I wanted to point out how management of this condition can affect overall mental, physical, and emotional health. So an individual's entire well-being is affected by their ability or inability to manage their gestational diabetes, and that's really important to me to kind of communicate and express. I wanted to pull this quote, and I'll read a little bit of it. A patient told me, "I think everyone wants to have a healthy baby, but they just become helpless and they can't take care of themselves." She said, "What can I do if things aren't available to me?" And I think this quote shows how someone's entire well-being, their physical, mental, and emotional health are affected by progression of a disease and ability to manage a disease. To conclude here, I wanted to go through some of the conclusions that I've got from my research, and of course the research and analysis is ongoing, so these will continue to develop. But the first conclusion that I came to is that understanding GDM is more than just understanding a disease. It's about understanding women's lived experiences in Karachi. And it also adds the existing literature on agency, inequity, and healthcare access. This research also brings about some theoretical questions that I will continue to investigate, so ideas about what narratives influence the discourse on access to care, and also who or what is responsible for the progression of a chronic disease. And then finally, I really want to emphasize that my participants were very articulate and clear with me about their tangible needs, things that they need the hospital, their government, or external sources to provide to them or make accessible to them in order for them to be successful in taking care of themselves. So things like access to transportation, safe places to exercise, support and knowledgeable family systems, and the ability to purchase necessary health care equipment are some of these very tangible needs that I hope to be able to compile and present to my research partners at Indus Hospital. And then finally, last but not least, I wanted to reiterate some personal takeaways that I had from this experience. The first personal takeaway that I had from this experience is I learned about the challenges of working in global health. Throughout the year-plus-long process of working on this project, there have been many setbacks and successes, and I've learned that working in global health requires you to be very flexible to your circumstances. I also, of course, gained a greater appreciation for my culture, family, and the city of Karachi. Everyone that I met when I was there was extremely welcoming, and I think that speaks to the character of the Pakistani people, and it's something that I continue to carry with me today. And last but not least, I wanted to express my gratitude to all of the women who decided to be a part of my study. I recognize that speaking to a stranger about topics like pregnancy, mental health, and diabetes is not an easy ask, and it's something my participants could have opted out of. And so I recognize, and it's not something that I take lightly, that these people and these women chose to be a part of my research, and it's something that I continue to be grateful for. And last but not least, I wanted to thank all of the people who helped to make this project a reality. Without any one of the people on this slide, I don't think the project would exist in the form that it does today. I wanted to thank the CSJ and the Global Health Institute, Dr. Oliver Johnson, Sophie Zhu from the GHI, and then also Dr. Sara Iqbal and Professor Van Hollen for your ongoing support in the design of the research. And of course, everybody else who is listed on this slide and helped to make this possible.
Thank you. Now I'd like to invite up Kayla to discuss her research with us, and she's the Laidlaw Fellow for Science and Public Health in the Modern Era, the Dismantling of Evidence and Institutions.
Good morning, everyone. I hope you all are doing well on this lovely Friday morning. My name is Kayla Wantumi, and I'm currently a junior at Georgetown School of Health, majoring in global health with a minor in science, technology, and international affairs. And today I will be presenting to you all my research project titled Science and Public Health in the Modern Era, the Dismantling of Evidence and Institutions. And before I begin, I just want to thank you all, those who are here in person and also on Zoom, for just taking time out of your schedules to attend this wonderful research symposium. So firstly, I just want to sort of outline the various components of my research project I will be going over today. So I will start off with acknowledgements, of course, and then transition into my introduction and research objectives. Following that, I will discuss my research methodology, and then I also included a brief timeline of various science and public health related events that have occurred this past year. And then after that, I will transition into my discussion and analysis portion, which is essentially the bulk of my research. And then lastly, I will conclude with some policy recommendations, just to leave you all with some key takeaways for the way forward. And then I also included my references in case any of you all are interested in taking a closer look at some of the sources that I use. So firstly, I want to thank and acknowledge the Laidlaw Scholars Foundation, as well as the Georgetown Laidlaw Scholars Program and the Center for Research and Fellowships, as well as my director, Colleen, for their continued support and promotion of student leadership and research. And then secondly, I want to thank my faculty mentor for this research project, Professor Hollaby, as well as the the O'Neill Institute at Georgetown, and then my co-authors on this research project. And then I also want to acknowledge my family and friends, again, for their endless support and encouragement in all of my endeavors. And then lastly, I want to thank the CSJ at Georgetown, as well as the Berkley Center, for putting together this phenomenal opportunity for students to present their research. And before I begin, I do want to acknowledge the fact that my research project is a very timely and sensitive issue, but I've maintained a very objective approach in my research that is rooted in evidence and also factual information from reputable scholarly sources. And this is not at all intended to be an attack on any particular individual or institution, but rather an analysis of an ongoing phenomenon that is occurring within the United States. So just to provide you all with some background information, over time, the field of science has become increasingly politicized in the US, and this has ultimately become more intense and heightened under the current administration. And various political actors have sort of leveraged science and cherry-picked scientific findings in order to push forward some self-interested agendas. And this is not only misleading to the public, but also undermines the longstanding work of scientists, researchers, and other experts in this field. And as a result, there has been a growing erosion of trust among the public within some of these science and public health institutions. So my first research objective was to sort of analyze the evolving dynamic between science and politics that we've witnessed over time. And then secondly, I wanted to examine some of the ways in which evidence-based research, as well as public health institutions, have been strategically undermined. And then lastly, just to synthesize all of my information and provide some suggestions for restoring scientific integrity and also guiding the way forward. So over the course of 6 weeks, I conducted a qualitative literature review in which I consulted more than 30 sources, specifically pertaining to science, health, as well as policy. And I listed some of the academic journals that I used in my search on the right here. And these are just a few of many. And then I also outlined some of my key search terms to, again, just narrow my research focus and filter these databases for suitable sources for my research project. And then on this slide, I've included a very brief timeline of some major science and public health related events that have occurred in the United States in the past year. So again, for the sake of time, I'm not going to go through all of them. And this list actually does not capture every event that has happened in the past 9 months. But firstly, I want to highlight the executive orders that were issued at the beginning of the year, specifically proposing the withdrawal of the United States from the World Health Organization. And secondly, another executive order that was issued that placed a 90-day freeze on US spending on foreign aid. And then about a month later, thousands of federal employees across the Department of Health and Human Services specifically were eliminated from their positions. And then in May, the White House released the budget request for the 2026 fiscal year that, again, just proposed substantial funding cuts to U.S. science and research. And lastly, in June, the Secretary of the HHS eliminated all of the standing members of the CDC, which is the Centers for Disease Control and Prevention, their advisory committee on immunization practices. And in my discussion and analysis section, I will further explain the implications of some of these events. So as I mentioned previously, the convergence of science and politics has essentially facilitated the manipulation of scientific research. And by nature, as we know, science stems from uncertainty as well as being a field that is constantly evolving. But this inherent characteristic over time has been reframed as a weakness as opposed to a strength of science. And as a result, there has been a growing distrust in scientific institutions as well as a decline in support for investments in research. And secondly, the COVID-19 pandemic actually provided us with a very unique lens through which the politicization of science has become more clear. And specifically during this time, misinformation and disinformation spread very rampantly across the US and globally as well through various news outlets and social media platforms. And this essentially perpetuated a dangerous cycle of ignorance as well as non-compliance with evidence-based public health measures. And then in addition to public health crises such as the COVID-19 pandemic, the politicization of science has also reached into fields regarding social dynamics, specifically pertaining to our understanding of disparities in society and also how these underlying factors are intertwined. And this subject has essentially been discredited rather than promoted and uplifted within research. And these dismissals not only undermine the research itself, but also the lived experiences of some of the communities that are facing these issues. And then lastly, there has been a drastic decline in the leadership of the United States, specifically on the global stage. And the US has ultimately lost some of its credibility as a scientific powerhouse, which has weakened its global health diplomacy and also disregarded decades long of multilateral cooperation. And in addition to the funding cuts that I mentioned earlier, as well as the proposed withdrawal from the WHO, the dismantling of the U.S. Agency for International Development has also had very evident and far-reaching consequences, specifically including stripping resources as well as humanitarian aid from low and middle income countries around the world, and also weakening the broader global health research infrastructure. And even though this move was framed as prioritizing domestic interest and also empowering low and middle income countries to uphold self-reliant governance, it has ultimately underestimated scientific progress as well as intensified the stark power imbalance that we see between the United States and low and middle income countries around the world. And while country ownership and domestic capacity building are very essential to sustainable development, the abrupt retraction of funding and aid is very detrimental to progress. And lastly, in light of all the information I just provided, I do want to leave you all with a few policy recommendations supported by my co-authors for the way forward. So firstly, restoring legal protections for civil service employees. As I mentioned before, over the course of this year, many civil service employees have been essentially slashed from their agencies without prior notice. And as we know, these individuals essentially lay the groundwork for very crucial scientific research and evidence-based policymaking within the United States. But unfortunately, they are often caught in the crossfires of political disputes. And then this recommendation is very essential to sort of safeguarding the rights of these federal employees and also upholding the fundamental principles of the US Constitution. And then secondly, codifying the independence of advisory bodies. As I mentioned before, many science-related advisory bodies within the United States have been subjected to a complete restructuring. So employing this recommendation with conditions such as reinforcing fixed terms or fair selection processes promotes these committees to exercise their own autonomy, but also further insulate science from politics. And lastly, instituting very clearly defined legal mechanisms for preserving scientific integrity can help restore the credibility of science and also regain public trust. And for example, the Scientific Integrity Act, which was a bill that was proposed in 2019, represents a very intentional and concrete step towards protecting science from the bias of politics. And key stakeholders that should work in collaboration to uphold these recommendations include the US government, as well as political leaders within the country, scientific experts, and then lastly, advocacy organizations and unions. And in addition to these recommendations that I just provided, the way forward should also be guided by sustainable investments, transparent policymaking, and active public engagement. And on this slide, I've included a QR code of my references, again, if any of you all are interested in taking a further look at them. But I do just want to thank you all for your time again and for listening to my presentation this morning. Thank you.
Thank you. I'd now like to invite up Aaliyah to give her presentation.
Good morning, everyone. I hope you're all doing well. My name is Aaliyah Hicks. I'm a junior in the School of Health, majoring in human science, minoring in global health. Today, I'll be discussing my research project titled Care, Culture, and Context, an ethnographic observation of healthcare in Cape Town, South Africa. At the intersection of care and culture lies a unique and complex lens through which we as students, researchers, and global citizens can examine if and how medicine is influenced by a community's local beliefs and social norms. During my time as a CRF Summer Fellow, I traveled to Cape Town, South Africa for 1 month, where I worked in Victoria Hospital, a secondary public teaching hospital in the Western Cape Province that serves a population of just under 50,000 with only 50,000 per year, with only 158 beds. I aimed to observe how providers adapt to meet the various needs of these patients. Now, what were the guiding questions that led me through this exploratory process? First, how do healthcare providers in South Africa navigate systemic barriers to Black and Indigenous patients' care? Next, what does provider behavior, communication, and clinical settings reveal about what role does clinical setting, communication, and provider behavior play in the delivery of culturally competent care? As I sought to understand these questions, I decided to take a grounded theory approach to my research, which essentially allowed me to develop a flexible framework through which I could observe the healthcare system, intentionally avoiding predetermined theories, in order to then form the groundwork that would serve as the basis of my future research. Ubuntu, I am because we are. This South African philosophy, born from community and tradition, remains a central tenet in healing practices in both clinical environments and in everyday life. As one of the most diverse countries in the sub-Saharan region, South Africa, with over 10 different ethnic groups and at least 12 official languages, was of particular interest to me. As a Somali-American student with aspirations of one day delivering culturally competent care to patients of all backgrounds in underserved communities, South Africa offered me a nuanced lens for exploring how a society, and more specifically a healthcare system, that has been heavily impacted by the legacy of both oppression and liberation functions today. My research protocol was as follows. I began with a preliminary literature review, then I conducted my fieldwork in Cape Town, followed by thematic analysis of the data, and lastly, I identified gaps in the existing research. Upon conducting a broad-scoping literature review, researching the legacy of apartheid, healthcare policy reforms, social determinants of health, systemic inequities, and more, I found that the long-term, unstable political and economic climate has led to numerous lasting impacts on the healthcare system. For starters, only 1.8% of the annual national health budget is spent on the administration of public health services. Additionally, each of the 9 provinces has its own Department of Health, which has led to fragmented governance and chronic underfunding. The healthcare system at large operates as a class-based structure, with 70% of providers working in the private sector, resulting in inequitable access to quality care. Leading me to my next point, provincial disparities. Spending in white provinces reached 200 to 300% more than in black provinces or Bantustans, disproportionately allocating support for staffing, quality facilities, and modernized technology. And lastly, when conducting my preliminary literature review, I was most surprised to learn that one of the most critical issues facing South Africa's healthcare system was what's commonly referred to as the brain drain. Over 50% of qualified physicians have been leaving in droves due to poor working conditions and the allure of greater financial opportunities abroad. Now that I was equipped with some foundational information of South Africa's healthcare system, I was ready to seek further insight through my fieldwork and observations at Victoria Hospital. You may be wondering, what did a typical day of data collection look like as both a student researcher from the US and a pre-medical intern primarily participating in an observer capacity? Well, our very own Dr. Arjun Shankar captured the essence of this research eloquently by stating ethnography helps us to see something about the world through interacting with it that we wouldn't otherwise be able to see. Therefore, I tasked myself with conducting informal interviews, interacting with patients, providers, and staff, observing communication patterns, clinical routines, and social dynamics, and also providing direct patient care. This multifaceted approach was necessary in order to fully immerse myself within the hospital's environment. I did this all while maintaining rigorous and comprehensive documentation. I used the coding key here to thematically analyze my data. While some research calls for deductive coding methods, my ethnographic participatory observation lends itself to a more inductive coding method, where themes emerged based on the data that I collected in a bottom-up approach. While not all are mentioned here on this slide, the most prevalent themes included contextualizing care, systemic inequity, systemic awareness, which is the recognition of or adaptation to structural or socioeconomic barriers in care delivery, health workforce crisis, education gaps, and advocacy. If you'd like to hear more about any of these themes, please ask in the Q&A section or the themes that I did not mention. The most prominent finding was the ways in which the healthcare professionals at Victoria Hospital maintained a deep systemic awareness of the barriers to care facing their patients, leading them to adapt care delivery to patients' background, education level, and environment. I saw this expressed in many different ways, but just to name a few, One surgeon had adjusted the excised margins during a surgery because they knew the patient would not be able to return for a follow-up treatment in an adequate amount of time. Another example was nurses altering the initial triage intake scores to expedite the time between arrival and being seen by a doctor. Even in the midst of substantial wait times, sometimes as long as 24 hours, one doctor covering 3 wards and several patients sharing a single curtain space, care delivery was routinely adapted to accommodate patients' socioeconomic and structural realities. As my research progressed, another key theme emerged. While I initially entered the field expecting race to be the most salient factor affecting the healthcare system in South Africa, given the lasting impact of apartheid, my research revealed that class, geographic location, and education level of patients more immediately influenced health access and outcomes. This was identified early on through a conversation with Dr. Balim, a psychiatrist who shared with me, the variation is enormous between rural settings and that don't have access, and private schools with 20 students with exposure to everything. Nevertheless, I observed this throughout the rest of my time at Victoria Hospital within various contexts and experiences. The last main finding I want to discuss relates to discharge practices and health literacy. Despite widespread compassion among providers, I found that patients were often confused about what had happened to them or what was going to happen next. There were clear gaps in communication, specifically surrounding procedures and post-operative care. One patient who had recently undergone surgery had told me, they're just trying to put something in my nose and they're not saying anything, they're not explaining anything. The same patient was being prepared for another surgery, and the informed consent process ended like this. Do you understand? Anything can happen in the operating room. That is why I'm having you consent to all of these things. The patient signed seemingly reluctantly. Unfortunately, this was not an isolated case. In fact, I regularly observed vulnerable moments of patients signing forms with little to no understanding of the procedures or the risk involved, being poked and prodded without so much as a hello, I'm your doctor, I'm going to be giving you this medication or performing this procedure. Even moments of patients calling out for someone to come and address their concerns and being ignored by busy doctors and nurses. Patients often missed follow-up appointments or didn't properly care for their wounds, not because they didn't care, but because they hadn't been given clear instructions or had no way to ask questions. This gap in communication between medical knowledge and patient understanding has significant consequences. One particularly staggering case, a patient came in expecting to get a routine wound cleaning. Instead, they were told they'd be receiving an amputation. The cause was sepsis from an improperly cared for dressing. This was a clear example to me of what can happen when low health literacy, rush discharge, and limited to no clinical follow-up collide. Following my experiences in South Africa, I returned to the literature. Current studies validated in South African populations support the aforementioned theme. One study found that 22% of patients admitted to a surgical unit experienced an adverse event, most of them being preventable, with 55% of them being related to clinical care and 18% related to systemic failures. Surgical site sepsis is one of the most telling indicators we have as researchers of the quality of surgical care. In another study conducted at Royden Hospital, a neighboring tertiary hospital in Cape Town, surgical site sepsis occurred in 24% of patients following an operation. The last supporting study found that 59% of patients who had developed a surgical site infection after cesarean section required readmission, and 35% of those were transferred to a higher level of care. To contextualize some of the data I just provided, this is a map showing sepsis-related inpatient stays per 100,000 people. DC specifically had a less than 1% rate of hospital stays related to sepsis. Surgical site sepsis, or surgical site infections, is often preventable, and these articles have highlighted major lapses in continuity of care and quality assurance in South African hospitals. This summer research experience helped me lay the groundwork, not just in developing a research framework, but in understanding the real-world complexities of bridging clinical outcomes and patient experiences, specifically in under-resourced settings. What may come across as abstract, like improving outcomes through communication, is in fact deeply tangible when you're in a secondary hospital where systemic constraints, time pressures, and language barriers directly shape care and recovery. My fieldwork in Cape Town underscores how modifiable factors like health literacy and discharge communication are often overlooked contributors to post-surgical complications, including sepsis and amputations. These risks are heightened in secondary public hospitals, which sit between rural clinics and tertiary centers and are often left out of mainstream research and quality improvement efforts. Knowing this, next summer I plan to return to Cape Town to 1, quantify the incidence of post-operative complications, particularly sepsis and amputations at Victoria Hospital, assess how health literacy correlates with key outcomes, follow-up attendance, infection rates, readmissions, 3, explore the efficacy of various discharge protocols, and 4, identify specific barriers to adherence, such as unclear communication, logistical obstacles, or language mismatch. Ultimately, my hope is that through this research, I'll be able to contribute to building a more responsive and equitable system, one that sees patients not just as clinical cases, but as people deserving of quality, culturally competent care. I would also like to sincerely thank the Center for Research and Fellowship, Penner Family Experiences Award, the School of Health Dean King's Office, Professor Kritz and Dr. Ardurian, all of whom were integral players in supporting this research endeavor, from funding to mentorship to recognizing the small work I've done so far and offering future support and guidance. And everyone here today, thank you so much for your time and for your interest.
Wow, what 3 great presenters we just had. Thank you so much to Amara, Kayla, and Aaliyah. And now we have about 15 minutes for questions for them. For those here in the room, please raise your hand and somebody will bring you a microphone. And if you're on Zoom, put your questions in the chat and they will be asked aloud here.
Hi, it was great to hear how each of you shared the importance of your research as far as whether it's like your academic goals, your future goals, your personal experiences with the topics. But I'd love to hear why you feel like it's really important to bring that back, have that experience as part of your Georgetown experience, and then have a platform like this to just share what you learned. Because we really appreciate it, but I'd love to hear from your end, like why it means something to you to have research opportunities like this at Georgetown.
Thank you for your question. I think, honestly, for me, there's a lot of reasons why this research was really meaningful to me. I think on the scale of personal development, really, I came into this project not knowing anything about research and going through the whole process with my mentors of designing a research project, going through the literature, applying to 2 different IRBs, and developing relationships internationally has made me a better communicator. It's made me more organized, and it's really informed kind of my passion and excitement for working in global health. And it's an opportunity that I'm really grateful for because it's given me so much experience kind of building this project from the ground up. Yeah.
Yeah, thank you so much for your question. So similar to Amara, I am also grateful for my opportunity to conduct research, specifically under the Laidlaw Scholars Program at Georgetown. And I am very passionate and deeply committed to advancing health equity, specifically across the globe. And this research project was particularly important to me and also very timely because I recently shifted my sort of academic focus from the medical route as well as more clinical settings to more of a policy focus and just improving my understanding of some of the underlying factors that affect one's health outcomes. And specifically, this research project has sort of provided me with more context and information within our domestic setting, and I'm hoping in the future to apply this to more global settings and conduct research as such in low and middle income countries to, again, just improve health outcomes. Thank you.
Yes, thank you so much for your question. not to reiterate what everyone has said so far, but I think for me, this research experience was very integral part of understanding the ways in which I, as one person, can identify the issues that I'm observing. I want to be a surgeon, a doctor, and so recognizing that there are issues within a system, rather than just being a doctor and supporting and participating in that system, I can actually address the issues that my patients are facing from a systemic level, and also work towards mitigating, those gaps in the research and identifying those gaps in the research.
Thank you all for the presentations. I had a question for Amara. I know you mentioned just like the sensitivity of the topic that you were researching, and generally like wanting to build trust with the interviewees. I was also curious how you built trust with the clinic itself, and the people that were working there, and if that was equally difficult, or if you found it to be very easy to like interact with them and enter into that space as a researcher.
Yeah. Thank you so much for your question. I think building trust was something that was top of mind going into this setting, because of course it was a hospital that I'd never worked with. Obviously going into, before I went to Pakistan, trying to set up Zoom calls and calls with my hosts was something that I tried to do, but when I was there, it was really important for me to meet with my host first before I went into the clinic to do the research. I ended up getting coffee with some of the resident doctors that I worked with, and also just making an effort to be there at the clinic consistently on a daily basis so that people got used to my presence. I became really good friends with the security guards who were at the front of the hospital, and I got them suites at the end of my trip. And so for me, it was really important to consistently show up, to show that I was interested, and also to make an effort to get to know people on a personal level. I hope to continue to kind of foster those relationships, because it was really meaningful to me to get to know the staff at the hospital, and I learned a lot from them about healthcare delivery, and admire them a lot for all the work they're doing. So, yeah.
Thank you all for this wonderful presentations. So we have a number of Hoyas in this space that hopefully will be applying to some of the fellowships that you all had this past year. So wondering if you could speak a little bit about the process of finding the fellowships, applying to them, and if you have any sort of advice or recommendations for folks who are interested in pursuing some of these other fellowships that you all had this past summer.
Yeah, so for starters, I think the most important thing is obviously identifying what it is you're truly passionate about. Maybe it's a question that you've been thinking on for a long time, or maybe you have two intersecting career interests. And so first identifying what it is you truly love and what you want to explore more of. And then I would recommend doing your research, as in looking at the CSJ website, the Center for Social Justice website, looking at the Center for Research and Fellowship website, looking at your individual academic school's website, and searching for keywords like opportunity, fellowship, award, research, and just gathering a comprehensive list of all of the opportunities that Georgetown has available, and finding which one of those opportunities essentially best meets your needs. Maybe you don't actually want to do research. Maybe you have a project or an initiative that you want to begin, and there are different opportunities for that as well. And then I would definitely recommend finding a mentor. Find someone who's done the research you want to do, who's in the field you want to be in, who has experience, and just ask them for guidance. Say, I'm interested in doing this kind of research. I noticed you did this. I was wondering if you would ever be available to have a chat and just talk through some of the ideas I have, and see if they're willing to accompany you on that journey. And then apply. Just apply to as many things as possible. The more you apply, the better chance you have of getting in. So.
Yeah, and just to add on to and expand to what Aaliyah said, so I actually heard about the Laidlaw Scholars Program through a friend of mine, shout out Fatia Fasasi, and I knew that it was certainly something I wanted to apply to, specifically because it focuses on key areas such as student leadership as well as research in such critical fields. And my recommendation is to just start to, again, as Leah said, search some of these opportunities, whether it's on the Georgetown website, the CRF website, as well as the CSJ website, and also just talk to some of your professors and faculty members, because a lot of times at Georgetown, the faculty are very involved in research projects, and they are ultimately like looking for more students to join their lab or their clinical research. And essentially with Laidlaw, how it works is you either apply to a faculty mentored project that has already been proposed, or you propose your own research outline. So I applied to a faculty proposed project. So I didn't actually have to write a research proposal, but with the application, I just wrote a statement of interest and expressed why I'm particularly interested in this research topic. And then I also met with the faculty mentor ahead of time just to get a better understanding of what he was looking for in a student researcher. So that is definitely something that I recommend, even throughout the application process, just meeting with various faculty mentors and just asking as many questions as possible to get a better feel for the research. And then I also recommend starting the application ahead of time, specifically with the Laidlaw Scholars program. If it's still the same, the application deadline was early February. So over the course of the fall as well as winter break, I specifically just started outlining and listing out various components that I wanted to include in my application for the program. And then I just continuously read over my application and submitted it. Thank you.
I completely agree with what was said. I will just briefly add on. I think that something that was really important for me was getting on as many mailing lists as possible, so that I can learn about what's going on campus, what the opportunities that are available are, and that's how I found out about the McKean Fellowship, is literally just being on the Global Health Institute's mailing list. So kind of allowing yourself to get as much information about what's going on campus as possible is something that's really important. And then also figuring out what exactly your interest is. And I found that taking classes that really interested me helped to pique my interest. I know I took a class with Professor Van Hollen on culture, reproductive science, and technology, and that really cemented my interest in reproductive health and politics. And so, yeah, so just kind of putting yourself out there and taking classes or going to research presentations to figure out what exactly your interest is and how you can apply that.
Hi, first off, thank you all for sharing your experience and knowledge with us. I'm passing along a question from Zoom, which is, what do you know now that you wish you had known before starting this project?
I think there are a lot of things that I know now that I wish I knew at the beginning. I think one of the biggest things that I wish I knew at the beginning was just how much flexibility, and I know I mentioned this in my project, but just how much flexibility it requires to work in global health, establish relationships with international partners, and to work with like multiple stakeholders. That was something that I learned to juggle with this project, and it's a skill that I will continue to take with me, kind of knowing how to proactively communicate with people, budget enough time for institutional review board applications and legal documents and all of the behind the scenes stuff that happens with research. I wish I knew before that, to just understand that I would have to be flexible with all of those processes.
Yeah, thank you so much. Thank you so much for your question. So one thing that I wish I knew before I engaged in this research was specifically the fact that I was going to be working with various co-authors on this project, as I mentioned before, as well as the O'Neill Institute at Georgetown. And when I applied, I knew the research project was sponsored by the O'Neill Institute, but I didn't know that I was going to be working with a team of researchers, and that might not be the case for all research projects, but I essentially, through my research, as well as my time in this program, I learned how to be a better collaborator, I would say, and learn how to, for example, write with people. Again, the paper that we wrote was a collaborative effort, so I had to make sure that I was reading over my work and making sure that it flowed well with the work of my other researchers. So yeah, cross-collaboration work is definitely something that I didn't have a very good perception of, especially in this high-level setting before my research project, but now I've definitely strengthened my skills in that field.
Yes, thank you so much for your question. I would definitely agree with what the other panelists have said, but just to give a little bit of a different perspective, I think one of the main things that I learned this summer was how our assumptions are always embedded in the research that we're doing. This is something I learned, when we ask research questions, there's always going to be an inherent hypothesized answer. And so for me, just recognizing what those assumptions were, the background that I'm bringing into this research, and trying to combat those assumptions in the actual application of the research that I was doing was something that I learned.
I think we're done for the morning, and lunch is being served.